Go ahead.
Aortic bicable cannulation, then we'll do aortic root pelagia pursing. We'll put aortic pelagia.
You should not say root. Okay. In the sense, where exactly do you take
pelagia
the
pursing?
Yeah.
Then
what pelagia you want to use?
Sir, delinidopelagia.
Okay.
Then
Okay. Find out. Do you know, miss, at what temperature will you cool him?
32 degrees, sir.
32. Why 32? Why not at 36? Why not at 30? Why do you cool a patient for doing cardiac surgery?
That for myocardial protection, sir.
For myocardial protection. No. What's the, miss, what do you use for myocardial? You're using del nido. Do you know what is the temperature that you will reach with del nido on the myocardium?
4 degrees.
No. 4 degree would be excellent, but usually 9 to 12 is the target temperature that you will reach.
The target temperature, please, we don't have time. Tell target temperature of blood cardiac picture is, any cardiac picture with blood is 8. Why? If you go to 4, what will happen?
At 4 degrees centigrade, what happens?
What happens? Some peculiar feature of water. When it starts crystallizing and the volume of the crystal is highest at 4, so it will actually rupture the cell membrane. So you never cool blood cardiac pictures to 4. You cool it to 8. Remember that.
Okay.
Then, so you don't know.
Go ahead. Now you have delivered cardioplegia. Go ahead.
Cross clamp.
Went the heart while giving cardioplegia?
No, not given, sir. Just the pursing.
Okay, it's okay. You tell how you will bend.
Then we'll go on pump. After that, we'll put right superior pulmonary vein vent. No, sir. Actually, there is mild AR was there, so we have to de-air.
So how does it matter for you?
Will the heart arrest or not with mild IR?
Yes, sir.
And why do you want to put a vent?
What do you normally do?
Yes, sir. Yes, sir.
Their approach is RF.
Oh, are you?
Look, fine. Fine. Go ahead.
Then
I don't want, I'm telling you, I'm your boss. I don't want you to put RSP.
What is the purpose of venting the heart?
sir, actually we have to first thing we have to while surgery that field should be clear.
Bloodless field.
Then
One. Yes.
First point,
That's
Decompress
okay. You can tell,
we have to
in
decompress
whichever
LV
sequence you
after inserting that vent. Third thing, while coming off bypass, we have to de-air LV. That also.
Not necessary. The purpose of LV venting, okay. The purpose of venting anywhere is actually to prevent distension of the heart. Distension is the biggest enemy for cardiac surgeon. So number one, there should be no distension of chambers. Number two, rewarming should be prevented because the perfusate temperature is higher than the cardioplegia temperature and the target temperature that we want for myocardial protection. Third thing is bloodless field. Okay, so these are important things why we vent the heart. So in this case, you are going to put a RSPV vent. It will only decompress the left atrium.
Left ventricle.
Okay.
Left atrium. And
He has a 0.7.
Gujarat, sir.
Now you are going to do the Butch and opening the cardiac center in Butch. This is your first case. What temperature would you like to put it?
The time you take to restore the circulation back, if it is long, you are surely going to lose the brain perfusion. Suppose you are at 30 degrees centigrade, you have a buffer possibility because the requirements have reduced now. So the time that you take can be little more and still the brain is protected. So to establish a layer of safety on CPB, you cool the patient. It depends on how comfortable and what temperature you want to do. Okay, so that is the intention of cooling the patient.
Okay, so if you say 28 as a beginner, I would like to cool more. Remember in the exam, we want a safe surgeon.
So the cooling is for safety.
Safety.
Okay. So there is no fixed rule 32 the way you are saying. So by that we understand that you don't understand why you are going to 32. So the intention is only as a layer of safety for you. Okay. Yeah. Go ahead. Now you have given cardioplegia.
Then we have we'll cross clamp and then we'll give cardioplegia. We'll arrest heart. Then we'll take IVC and SVC snares. We'll then snared. Then we'll open RM. We'll open IS. We'll examine.
How do you open the intraatrial septum?
Sir, before opening anti-aortic septum, I will ask perfusionist to fill the heart. Off the vent. Then it will be filled. I will open IS at the level of fossa ovalis. I will open.
Down or up?
Up, sir.
Superior margin.
Superior margin. Then I will retract IS. I will.
No. You have just made an incision in the fossa ovalis. Now, how do you extend this incision? You have to extend this incision.
Yes, sir.
It's a very small, fossa ovalis is very small, isn't it? How do you extend it?
Superiorly. We will open superiorly, sir.
No, you will have to extend both superiorly and inferiorly. Okay.
Superior or inferior?
How far?
No, first answer. Which way?
You have plunged the knife. Why did you plunge in the superior part of the limbus of fossa ovalis? What will happen if you plunge down?
So you always plunge the knife where there are no structures behind. So that is why you go to the top part of the fossa ovalis. Once you open that, okay, and the blood is emptied of the chamber, extend this incision to the base, that is towards the mitral valve, till the muscular portion. Don't extend beyond the muscular portion. The second part, that is the extension superiorly, is guided by the midpoint of the SVC. You are always seeing the SVC when the RA is open. If you extend this incision to the midpoint of the SVC, you will reach the roof of the LA. You stop there. This is the maximum extent that you can do so far. Okay. Now you expose by putting retractors. Now you continue.
You want to put retraction suture?
Yes, sir. Stays will take to RA and IS. Then we'll retract with the Prolin 30 or 40. We can take. Then mitral valve examination will do. We
Never see the mitral valve.
After taking your stay sutures, what is the first step?
will examination LA cavity.
You examine the?
LA cavity.
Okay.
We'll see clot.
That's what better.
What are the potential sites for the thrombus in the LA?
In LA appendage.
LA appendage.
LA appendage we'll see. Then pulmonary artery.
No,
first.
no.
No pulmonary artery is there.
No, that's okay. Pulmonary veins.
Pulmonary veins opening
Ostia.
sites we will see.
Okay.
And over mitral valve.
Okay.
So LA appendage is full of clots. Then what do you do?
Can you see the thrombus in the LA appendage?
Yes, sir.
If it is sitting in the tip of the appendage, you will not be able to see. So you invert the appendage, visualize it,
Yes, sir.
okay, and you put it back. Okay. After this stage, after you have made sure that there are no thrombus in the LA body in any of its components, then what is the next step?
Then mitral valve examination.
Okay.
Then leaflets.
I can't see the mitral valve. I don't see the mitral valve.
LA appendage.
How will you expose the mitral?
See, do you want to see the address the mitral valve first or the appendage first?
Appendage first.
How do you close the appendage? Do you regularly practice?
Mitral valve. Appendage examination we will do first.
There is a clot.
There is clot. Then we'll remove clot. Then
Removal of clot. You will close the LA appendage or not?
Now what do you do with the appendage?
we'll plicate LA appendage.
You need it like
No, it's not called plication. Plication, you just want to, that's your intention is you close the ostia of the LA appendage. That's what
Yes,
you
sir.
mean? Okay. So the base of the LA appendage you want to close.
Yes,
Fine.
sir.
How can you kill your patient at this stage? By closing the LA appendage, you can potentially kill the patient.
What is the danger during this closure?
the depth of bite.
Can you kill the patient? In cardiac surgery, we can kill the patient all the time, but in this case, specifically, how can you kill the patient?
So what are the most important structures around the mitral valve annulus?
Mitral valve, there will be LCX will be there,
Yeah.
coronary sinus,
Yeah.
and conduction.
So can you tell where exactly the circumflex artery would be there in the place where you are talking about?
At the anterolateral commissure.
So between the base of the ileal appendage and the annulus of the mitral valve, if the bites are deep, okay, there is a potential possibility of injuring the circumflex. So that's what he was trying.
And another is, if you take a deep bite, after you came up palm, you will see the bleeding from the base of the ileal appendage. So after placement of mitral valve, that is difficult to control. So your bite should be not so deep. Means the needle should not go out of the cavity. And another is during taking bite, there is the chances of injury to coronary sinus is less. Coronary sinus is towards the right side, not at the near the base of the ileal appendage and mitral annulus. The circumflex artery is there.
Just remember one thing, whenever anyone asks about the surgical anatomy of mitral valve, you should tell about in relation to a clock. That is easy to depict.
Okay.
Sir has asked about what are the relation of various structures to the mitral valve. So you tell it in a clockwise position.
You know, wherever we talk about clockwise position, what it means?
Yes.
Tend to
Explain.
Means-
When you are operating, you are standing on the right side, you have the mitral valve is retracted.
So
now
from
what is
nine
the meaning
to
of
12
clock position?
I'm sorry. Can you draw the diagram?
No, it's okay, come, I'll simplify it.
Yes.
What clock positions means anywhere you read is, actually the surgeon is standing and holds his wrist to see the watch. That is the clock position. Okay? So whatever is the clock position, you can talk.
Sir,
Now you explain to them the relationship of various structures that you encounter around the mitral
Sir,
valve.
Can you keep talking?
Now you go ahead with the steps. Let him finish the drawing.
for now we will examine mitral valve.
Continue, go ahead.
Mitral valve will see leaflets, will see subvalvular apparatus, calcifications extend, then we'll start
What is the objective of you examining the mitral valve?
objects.
Means what is the purpose?
Means we have to do mitral valve excision. So
Exercise करने के लिए थोड़ी exam करना पड़ता है. Excision means you are going to exercise. So the objective at this stage is whether it is still you feel that it can be repaired or not. Okay.
yes.
So that is the purpose of examination of the valve. Otherwise, if excision is the objective, then you just go ahead with the further steps of mitral valve excision. Okay. So for now, we will limit our discussion to mitral valve replacement. So you tell the steps of mitral valve excision and replacing with a prosthetic valve.
Sir, we'll start excision of AML first. We'll put incision at 12 o'clock
Why?
because there will be no important structure beneath that beneath that area. And
So how do you identify where you have to put plunge your knife in the 12 o'clock position? How do you identify?
so there will be white color mark will be there. Annulus will be there.
Can you see mitral valve annulus? Okay, so the thing is, you will never be able to see the mitral valve annulus. It is not seen. What you see is actually the hinge line of the mitral valve. What white line you are saying between the muscular pink zone and the white zone of the leaflets, the junction is called as the hinge line. Annulus of the mitral valve lies deeper. It's about 2 to 3 millimeters outside this hinge line. So it's not the annulus. So you will identify the mitral valve hinge line and you will spare a little bit of tissue, that is 1 or 2 millimeters,
1 or 2 mm.
and then plunge the knife at 12 o'clock position because there are no important structures beneath this. Okay?
Yes, sir.
This is the starting of the excision point. So how do you continue?
Underneath it? You said no important structures underneath it. So what is that gap which you see there when you plunge the knife?
Cavity will be there, sir.
What
LV cavity.
Yes.
What part of the LV cavity?
Cervical cavity.
Just above that is what?
Left ventricle outflow.
LVOT.
LVOT.
Aortic valve is sitting like this. Then the cavity is here. It cannot collapse because it is the LVOT, which is splintered open by the aortic annulus.
So now you have plunged the knife, you have not injured any structure, how do you continue?
Then we'll exercise AML, just 1 to 2 millimeter medially to that hinge line. Yes, curvature scissor towards me, sir. Yes, sir.
You start here.
Yes, sir.
Okay, then
Then we'll go.
come. I'm not going to bite you. Come.
Sir, we'll go this side and we'll take care of LCX. It should be 1 to 2 millimeter in.
No. You want to, we are just make the stab, then we are going this way. So you want to cut the whole valve and then take sutures, or you will cut, take sutures, cut, take sutures, cut, take sutures.
We'll first we'll cut in medially, and then we'll divide in 2 parts. Then we can cut AML.
You want to, okay, all right. How do you normally do in your place, you tell us? Okay, let us make it very simple for you. This valve is not calcified. We are just telling the basic steps for MBR. What will you do? If it is calcified, then preservation and all will become a problem. So let us not get into that. Simple, straightforward mitral valve replacement for pure stenosis without calcification. You start here, you excise the valve, you save the posterior leaflet. That's what you want to say. But how will you take your sutures here?
Sutures, sir, first 2 sutures will be taken at the.
No, beta, you will cut and take your sutures, or you will cut the whole leaflet and then take the sutures.
Cut the all full leaflet, then we'll take sutures.
Well, I will tell you what exactly he wants you to tell. See, when we are retracting the, we are retracting the intraatrial septum, usually the toughest area where to take the bites on the annulus is actually the anterior midline, that is the 12 o'clock position.
Yes, sir.
That is the tough piece. So what he is trying to say is, once you incise, the annulus is clearly seen. Would you want to take the sutures now at this stage only? That's the question.
Do you hold the leaflet with anything?
Yes, sir.
You can use a pulsar or you can use a Alice or a copper or something and you pull. This is called the bonnet technique of Craig Smith. It was originally described by Craig Smith, where you actually hold it like a bonnet, car bonnet. Open it and pull. This brings the anterior annulus into vision. Did you understand?
Yes, sir.
Described by Craig Smith.
In this case, do you think the mitral valve will be visible better? Have you seen the echo? Do you think it will be easy or difficult? Have you seen the echo? What is the?
You see the next page.
So what is the LA dimension?
Oh, yes, sir. It's 6 in.
Easy mitral valve replacement.
61 millimeter, what do you think? So, big, small?
LA enlargement.
In Bigada, Thoroughly addressed put here.
So do you read?
Would you like this case?
No, sir.
No?
Arey Baba, 61 easy. You can
It is so.
sitting in the mitral valve.
Means we can go from LA approach also if.
At some point,
Baba in any
Irrespective of the approach,
Change
this
your
valve
approach.
will be seen better. You don't have to struggle is what we are trying to say.
Okay.
so at some point of time, 6 centimeter was considered as giant LA at some point. Okay. So it is a huge LA. So it will be a comfortable approach. Exposure will be comfortable. So your mitral valve will be very clearly seen in this case. Okay.
See, because once you cut the whole thing and you take your sutures, it will get difficult. So you cut a few millimeters, take 2 sutures, cut a few millimeters, take 2 sutures for the anterior thing. Then the posterior one is visible to you. That is what we are trying to tell you.
Okay, now that the incision has been started from the 12 o'clock position and you have reached 9 o'clock and 3 o'clock positions. That's where you stop.
Yes.
Continue now.
Then we'll remove the leaflets and we'll preserve the cords.
No, for now I think we will stop. We will omit this caudal preservation techniques. If you have read well, then we will go there. Okay.
Want caudal preservation?
Just go ahead with mitral valve replacement. That's enough.
Okay.
So when you reach 9 o'clock and 3 o'clock position and you are giving traction on the AML, you will be able to clearly visualize the chordae attached to the papillary muscles.
Yes, sir.
If you split them from the papillary muscle heads at this stage, the rest of the mobilization of the leaflet is easier. So at this stage, most surgeons would chop off the chordae from the papillary muscle heads, and that brings into view the PML hinge line. So you can extend. Okay, that's the point.
Where do you cut
The chordae.
Why do you cut the chordae only? Why not the papillary muscles?
Sorry, sir.
Why do you cut only the chordae, not the papillary muscles? You will get more space for the valve.
Sir is asking, why not chop off the papillary muscle?
So it
Unless you are having mitral stenosis, small cavity, let us exercise, chop the papillary muscle. It will give you more space, no?
can be bleeding, sir.
Are bleeding?
No.
Yeah, what bleeding? Yes.
There can be LV injury if we are cutting
You
everything.
cut so deep, that means you have made a hole in the LV. That is what you are saying.
Yes, sir.
No, not that much.
That is too much.
What is the, where do you supposed to cut? Do not cross something. It is all there in black and white, red and I'm giving you the thing, man.
What is the color of the chordae?
What is the color of the chordae at the tip of the papillary muscle?
Whitish color,
And what is the body?
pinkish color.
Why is it white and why is this brown? Brownish red.
Muscle and this is fibrous.
Yeah, blood supply. will-
Restrict your incision only to the fibrous part. You will never go into the muscular part. Because why? If you go into the muscular part, what can happen? Yes, bleeding occurs, but not where? Not intracavitary bleeding. Something else worse will happen.
There will be atriomitral junction. Below that junction, there will be bleeding, sir. If we are
that is different.
injuring papillary muscles.
No, you are deviating from it.
Please read up about types of ventricular rupture 1, 2, 3 by Don Treasure and this is
Okay, so we are continuing with the posterior leaflet. Now, anterior you have taken the sutures. Complete the posterior part.
Caesar is continuing.
Posterior leaflet, sir, we can preserve.
I find that it is blobby calcium and we want to remove it and make artificial cardiac, but now it's blobby calcium. Can't see to the valve. How will you exercise?
Anybody in the
Okay,
audience
sir.
can help.
Sir,
Sanna, I was thinking that should we go for the next case? So this was gone for a long time.
okay, yeah.
So, but
Your aortic regurgitation
Or you
is
want to
mild.
give another 5 minutes?
Yeah, another 5 minutes we will close this. Yeah.
Okay, okay.
Yeah, now somehow we have explanted the mitral valve, excised the mitral valve completely. Go for mitral valve replacement with prosthetic valve. Tell those.
Okay. So
Sutures taken for all the
your aortic valve regurgitation is mild in your echo.
Sorry,
If
sir.
it is moderate, then is there any change of plan of your surgery in presence of severe MS with moderate AR? Moderate aortic regurgitation in presence of your MVA 0.7 centimeters square.
Yes, sir.
Could you change your plan or
Plan.
regarding aortic valve?
Aortic valve. Actually,
Will you leave that or do something?
aortic valve, mild AR only there, sir.
No, if it is moderate.
there is moderate AR. What is your plan?
Moderate AR.
It's okay. Now stick to the mitral valve replacement. Yeah. Now you have taken pledgeted sutures all around.
Yes.
Next, go ahead.
Then we'll take suture from the valve position will be the
That
anatomical
you
position.
can. Okay, fine. What do you mean by anti-anatomical position?
It will be Seven.
in the
Now,
diagram.
what is anatomical position? Normal anatomical position?
1 o'clock to 5 o'clock.
No, it's
1
not,
o'clock to
nothing
7
to do
o'clock.
with that. I'll tell you. Anatomical position of mitral valve is the posterior part of the LV cavity is the inflow. The anterior portion of the LV cavity is the outflow. Okay? The blood moves along the posterior column more posteriorly and comes anteriorly. So this is anatomical. Anything in perpendicular direction to this is anti-anatomical position. That's all it means. Okay? So based on that you seat the valve. Okay? Now, you wanted to implant a mechanical valve. Unfortunately, the nursing staff they have opened and removed the holder also. Okay. Now, how will you know whether you are going to put the valve in proper direction or reverse? Do you understand the question? Yeah.
Sir, onyx valve is bileaflet valve.
No, it can be any valve.
Sir, valve
principle of-
leaflets, the superior surface will be convex surface.
So if you hold it upright in your hand, the valve should open for the mitral position.
Okay.
Isn't it?
Okay.
That is how you are going to implant
Yes.
it. So if you hold in your hand, all the holders have been removed. The valve leaflets should open in that position. That is the proper way to implant the mitral valve. But the same thing for the aortic valve will be reverse.
Reverse.
It should close.
Yes.
That's all. It can be for any valve. If you come across for bioprosthetic valve, the strut should always face the LV cavity for a mitral valve. It should face you for an aortic valve. That's the.
Yes.
Go ahead.
So valve seated.
Where you will be careful while taking the sutures? This is what we want to know.
Sutures, sir.
Okay. Fine.
How
do
can you
take
kill
the
the patient by
How do you
taking
take the
sutures?
sutures and what
Sorry.
suture material do you use?
How can you kill the patient while taking the sutures?
Sir, there can be LCX injury
Where?
here. Means LCX will be till here. P1. This will be.
Okay, I agree. Now you go there. But what are the ways you can kill the patient?
Then there will be conduction bundle branch block where if you are taking suture from here.
You don't kill there. You can put a pacemaker. What is it that you will tell your assistant when taking the bites in between 9 and 6 o'clock there?
9 and 6.
Something your assistant should contribute to the surgery. There is a very famous picture in Harlan and Starr, and if you go to KM, you will find lots of specimens where we have killed patients.
Where
As
LCX
students.
coronary sinus injury can happen.
No, people don't die of a coronary sinus injury. I have yet to see, you can ligate the coronary
Yes, sir.
sinus and you will not die. That is old treatment. You don't know. We don't have time. Please remember, this is very beautiful. If you have seen a textbook called Harlan and Starr, if you see the ventricular cavity, then you will again see a line here. I'm just exaggerating, the line is not that big. This is white and this is red. All bites should be taken only in the white area, not in the red area. If you go to the red area, what will happen is when you tighten, you will get a
Cut through.
tear in the muscle. You will see nothing when you are, there will be nothing happening at that time. When you try to go off bypass, this tear, blood will seep through this and you will get what is called as an AV groove hematoma, and that AV groove hematoma will rupture and cause bleeding behind. All of you, there is a book called as Harlan and Starr where there is a beautiful description of that. Okay? That is another way. Not only the circumflex, you can go and mix the circumflex, but you must remember never cross red-white junction. So, assistant should be seeing, you should be taking the bite, and if you go into the red, you have to warn.
So, Balram sir, shall we close this case?
I think so. You can assess them. How do you assess them?
In my assessment, they have done well, sir.
Yeah, fairly well, but they got to improve further.
Yeah, I think they can be more going in a flow of what the examiner wants to know, one. Two, I think these are very basic surgeries. I think the anatomy related to this must have been bombarded so many times regarding important structures around the annulus. You should be more fluent with that. And third thing, I think you should think more in terms of really practically doing things, not theory. Means understanding theory is one part, but I think what you do every day, I think that should be very strong. Okay, because finally you will be able to do these things. Being practical is very important.
Very nice. So, second case?
Shrikant,
The next case. There is only.
only one case?
I was told two cases are there.
We will go for the second case. Oh,
Let us be a bit short on that one. So, we start with the diagnosis.
Yes, sir.
Features.
Presenter of residents who are presenting, just don't get afraid. Take a deep breath, as sir is repeatedly saying, and answer confidently because you are murmuring in the mic, so there is no sound coming here and there. Please. And do as many mistakes as you can do. They are here for teaching all of us. Please.
the format will be, we will start with the provisional diagnosis,
Yes,
and then we will lead the discussion further. Okay?
Okay, sir.
Yeah.
Good afternoon, everybody. My provisional diagnosis for a case is a acyanotic congenital heart disease with increased pulmonary blood flow, likely to due to a post-tricuspid shunt, possibly a restrictive VSD, with no features of pulmonary artery hypertension and no features of congestive heart failure or infective endocarditis. My patient is currently in ROS class 1.
Excellent. This is
You should
actually
tell
the
about
way
rhythm also, NSR.
normal sinus
And normal sinus rhythm, sir.
Yeah.
Yes, sir.
Yeah. Now, can you substantiate each part of your diagnosis?
Yes, sir. So in my history, this is an 8-year-old boy who initially was asymptomatic till the age of 2 months of age. His symptoms at 2 months of age, noticed by his mother, was forehead sweating during feeding, and there was sucrose cycle.
No, I would not want like this. How I would want is, acyanotic congenital heart disease, how did you get it? Then you said VSD, how did you get it?
Yes, sir.
Restrictive, how did you get it?
Yes, sir.
Okay, that's.
So history, there was features of sucrose cycle.
Acyanotic heart disease. Why did you say acyanotic?
Yes, sir. There was no history of cyanosis, sir.
Yes.
From the history.
Correct.
And in diagnosis.
That is the reason.
Yes, sir.
Next.
And next.
You measured the pulse of,
Yes, sir. In examination.
how much was it?
It was 99, sir.
When do you say there is cyanosis?
If it's below 85, sir.
Really? When do you say there
If
is
the-
systemic? Listen,
Yes, sir.
when an examiner is talking, do not
Sorry, sir.
hear the question. When do you say there is systemic desaturation?
Sir.
Arey, look at his hand. When do you say there is, you were doing COVID
Sir.
duty?
Yes, sir.
In
Sir.
COVID duty, when were you sending the patient to the district level hospital and when were you sending to the tertiary center?
Less than 90, we would send to 95, we would send
95, less
to
than 95, you will
district
send
level
to
hospital.
local.
Yes, sir.
What was the number then? Systemic desaturation is below
95%.
below 95.
Yes,
Then
sir.
when do you send to the higher center?
Below 90, sir.
92.
Okay, sir.
Why? Because the oxygen saturation curve dips at 92 literally like a press release. Okay, next.
Okay, sir. So in history wise,
You are going back again and again there.
Okay.
You just have to substantiate each part of your diagnosis. So you substantiated, why is it acyanotic?
Yes, sir.
Second part of the diagnosis was,
increased pulmonary blood flow, sir.
why do you say that it is increased pulmonary blood flow?
Recurrent respiratory tract infections, sucrose cycle, and there was forehead sweating during feeding, and also there was poor weight gain noticed by the mother, sir.
Okay. Next, third part.
Third was a post-tricuspid shunt, sir. This I said because the onset of history was after 8 weeks, 2 months of age, sir.
You have to tell the clinical examination part also to say
Yes, sir.
when you say it's not just the history, it's
Yes, sir.
Casting as an integrator.
Yes, sir.
In clinical examination, not only history taking, what else did you see?
Yes, sir.
There is increased pulmonary blood flow.
हाँ मनु
So there was a presence of cardiomegaly was there, sir, and cardiomegaly was there, which was my apex beat, which was cardiomegaly, and hyperdynamic apex, sir.
हाँ
I could not appreciate active precordium on the on my examination, sir.
There is increased flow through the pulmonary artery.
Just 1 second. You said you couldn't appreciate the parasternal heave. Something you said just now?
Yes, sir.
So is that in your favor or it is against you?
Sir, it is against the left to right.
Huh?
I mean, it is parasternal heave is for right ventricular hypertrophy, sir, which is seen in pulmonary artery hypertension.
No, so is this in your favor or not in your favor? There's no parasternal heave. So it is good for the patient or bad for the patient?
It is the bad for the patient. Onset of pulmonary artery hypertension, RVH, sir. My child is 8-year-old boy. That's why I had mentioned.
It's good if he doesn't have it, no?
Yes, sir. It
you
is
said
good
it
for
is
him, sir.
it is restrictive VSD. Restrictive VSD
Yes, sir.
means there is no pulmonary artery hypertension.
Yes,
so
sir.
why you expect the parasternal heave?
There was no parasternal heave, sir.
So that is good for the patient, no?
No, sir,
It is good for
he
him,
says
sir.
there is no parasternal heave.
Is it good or bad?
It is good for, sir.
You were telling bad, ma'am. Then what is there to tell there is pH, ma'am? Simple thing.
Are there any
Sir,
findings?
T2 was not loud, sir.
Is it good or bad?
It is good for the patient, sir.
Tell that he doesn't have pH.
Yes, sir.
P2 is not loud. All your statements are is not was.
Yes, sir. He's not loud, sir.
So essentially you are concluding there is no evidence of PAH.
Yes, sir.
Yeah.
Sir,
Any flow murmur? Any flow murmur?
no, sir. I could.
Pardon? Where did you hear the flow murmur?
Sir, flow murmur, I would expect it across the mitral area, sir. An inflow, early diastolic, mid diastolic murmur would be expected. I could not get it, sir.
Means physiologically what is
So that means
It
what?
is a restrictive shunt, sir. Not less than QP
What do you mean by
QS.
restrictive shunt? How much?
Less than 1.5:1, sir. QP by QS.
Or you can say less than 2:1.
Yes, sir.
Whatever you say. Okay? Alright. Did you get any ejection systolic murmur?
Pardon me, sir.
Any
No,
ejection
sir. I
systolic
did not
murmur?
get a ejection systolic here in the pulmonary.
So why do you say there is a shunt at all?
Sir, I could get there was a harsh, high-pitched pansystolic murmur heard in the left third and fourth intercostal space, sir.
Okay. So sometimes when you have got the harsh pansystolic murmur, can it be a very small VSD?
Yes, sir.
What do you call it?
A restrictive VSD, sir.
No, what this murmur is called?
Malady de Rogers.
Yes, sir.
Yes, that's right. That's right. She's right.
No hepatomegaly was there, sir.
Sir.
Why do you get a high pitched murmur?
Pardon me, sir.
No elevated JVP.
There were no features of elevated JVP, sir. Yes, sir. And no hepatomegaly. And
Why is it not MR?
sir, there was no. It was not. The murmur was not radiating to the axilla, sir. And
What is?
pardon?
You should say the location of the murmur. Where did you hear the murmur? It was not at the apex, no?
Not at the apex, sir. Mitral area.
So, a murmur will be at the apex, radiating to the axilla. This must be along the left sternal border,
Yes, sir.
right?
Yes, sir.
Okay. Okay. Investigations?
You are doing good.
Pardon me, sir.
Continue.
Okay.
Investigate.
Investigations. Okay.
Read.
Is it compatible with your diagnosis of a VSD? Yes, no.
Can't see anything.
You have said VSD, right?
Yes, sir.
Is this ECG compatible with your diagnosis of the isolated VSD? Yes, no.
No, sir.
No.
There is no features of volume overload, LV volume overload. However, I can see features to suggest
What are you seeing in V1?
V1 there is a biphasic P wave, sir.
Really called a
Yes, sir.
biphasic V-wave.
That is T wave is inverted, but I can't
duration is
appreciate the
not-
biphasic P wave.
It's
Where is the biphasic P wave?
sir, there is RSR pattern is seen, sir.
Yes, that I
RSR
agree.
dash R prime pattern is seen, sir.
That I agree, but where is the left atrial overload? There is no biphasic P wave.
No, sir, he said there is no evidence of LV volume overload. That's what he said.
Okay,
Yeah,
all
yeah.
right, all right, okay.
So in presence of small VSD, your LVAs may not be there.
Yes, sir.
But
If you get a RSR dash in V1, what should you also suspect?
I would think of pulmonary artery hypertension, sir, and right.
R dash is less than 1.
Yes, sir, it's less than right bundle branch block. I would think of, sir.
Incomplete right bundle.
Yes, sir, incomplete right bundle.
Something which is commonly associated with the IRBBP.
Chest X-ray?
X-ray,
You
Shrikant.
should also suspect a concomitant ASD.
Yes, sir. Chest X-ray.
Does that go with your diagnosis or chest X-ray?
Correlate with your diagnosis.
Yes, sir.
No, this
Does it go with
X-ray,
your diagnosis?
this X-ray, does it correlate with the findings that you told? What were the most important findings that you said? You said first asynetic, left to right shunt, increased QP.
Yes,
No
sir.
evidence of PAH.
Yes,
No
sir.
evidence of chamber enlargement. Isn't it? No PAH. This X-ray.
No,
Read
it
the
does
X-ray.
not. It does not corroborate with the other findings.
What is the first finding that you will say in this?
Pulmonary.
There is an LV type of apex. There is
No,
LV.
heart is enlarged or not?
It is. There is cardiomegaly.
Yes.
There is.
Is it LV apex? Is it LV type of the apex?
There is a little catch to this.
It's biventricular. I mean, the
No,
LV
no,
type
forget
of
that. Apex. Comment on the apex.
Apex.
Yeah.
Apex downwards or outwards?
Given the collar line, normally, should you see, can you see this? Yeah, but then there is a problem here. Now please be aware that this is a trap. If you see that 1, 2, 3, 4, 5, 6, 7, 8, 9. If I were to keep it like this, now what would you call it as? Elvident. This lung has been pushed down. There is air trapping. It has pushed down. Can you see the diaphragm is flattened? If you say this patient is asymptomatic, I will strongly challenge you. This patient should not be asymptomatic with this much of air trapping.
Okay, you tell us the findings on the chest X-ray. What are the findings on the chest X-ray?
Okay, this is a PA view chest X-ray, well centralized, adequately exposed, showing situs solitus.
This is the
levocardia.
problem, okay. When you come to pediatric, the most important thing will be increased flow or decreased flow. That can be commented only if the exposure is optimum. In this, it is not properly exposed. That's what I said. The spine should not be seen at the cardiac shadow. Okay, if it becomes to that level exposed, the pulmonary vascularity will be more prominent in it. Okay, so go ahead. We will assume that is properly exposed, and you go ahead with the findings.
And always, in a systematic reading and short distance, remember, first place the viscera, then place the size of the heart, and then go around the bottom of the heart and into the cardiac shadow, into the lungs, into the bones, into the soft tissue and out. You will never miss anything.
Okay, Prasanna, let us speak first.
Go in that sequence.
There is cardiomegaly, situs solitus, levocardia, fundic bubble.
There is no funding bubble there. So what will you see?
Right bronchus,
See the bronchus. Next, continue.
situs solitus, levocardia, levoposition, and cardiomegaly is present. CTR is 0.55. We can see there is an LV type of apex. There is straightening of the left heart border. Pulmonary area is full. Pulmonary vein is full.
Prominent, not prominent.
It's
Aortic ductal big or small?
small.
Small. Means what?
Left right shunt.
Not just a left to right shunt. It is stolen, the blood is stolen away from the aorta. Means what?
MPA segment is full.
Means what?
Increased QP.
There is increased pulmonary flow, or it could even be stenotic. We don't know it. We'll tell you later. Then next, appendage.
LA appendage is enlarged and
Means what?
LA dilated.
LA dilated means which shunt?
Left to right.
Which shunt?
Ventricular shunt.
Ventricular. We've already faced shunt. Next, ventricular contour is biventricular. We leave that because of the pushing down. Right heart border.
Right heart border also, we have some right atrial enlargement.
Left atrial.
Yes, there the carina is splayed. There is, I mean, I cannot appreciate, but a double density.
That is all LA. Then lung field.
Lung field, there are pulmonary plethora. The right descending pulmonary artery is prominent, and there are some end-on vessels also. More than 3 end-on vessels are present.
Flat red appearance.
So these are all features suggestive of corroborating with a left to right shunt and a VSD with the signs of LV volume overload and but
what?
Does your X-ray findings correlate with the diagnosis and the history?
no, according to our history, it is a restrictive VSD, and according to this, the shunt fraction is significant.
Yeah. So there is a discrepancy. No? Yeah. Next. In echo for congenital heart disease, what should be the sequence of reporting?
First the segmental analysis.
Yes.
Then situs, soletus,
So
levo.
just tell the sequence for a normal heart.
Situs, soletus, levocardia, normal.
Loudly and clearly. Situs soletus, levocardia.
Normal systemic and pulmonary venous drainage.
Normal systemic and pulmonary venous drainage.
Then the chamber enlargement.
No, relationship of the great arteries.
Okay, relationship of, sorry.
It's
Relationship
a very
of the great
important
arteries.
thing. Okay,
Yes.
normally related great arteries. Then
chamber and chambers, individual
chambers. Okay, atrioventricular.
Remember SES. What is S?
Situs.
B.
The
B.
is the sir. Yes, sir. The levocardia, levo position apex.
D. I will come like this. D.
Sir, the rotation of the heart, the thumb is put into the inflow and outflows in the.
Chirality of the heart.
Yes, sir.
D loop.
De-looping of the heart.
Chirality of the heart. D
Yes, sir.
loop.
You know what is D loop? Write it down. Go and check today.
Find out
Yes, sir.
what is D, what is L. SD. Then the third S. Relation of the
Great artery.
What is that S, third S?
Pardon me, sir.
What is the third S standing for?
Si-
SES, third S. No, don't know.
I don't know.
Sometimes it's better to tell I don't know. It is a soletus relation of
Yes,
the
sir.
great arteries. What is the soletus relation of the
So the
normal to the great arteries?
ventricular arterial concordance, left ventricle.
What is meant by the soletus relation of the great arteries? Listen to me. Close
Yes,
your eyes. Take a breath. Take one more breath.
Stop breathing.
And take one more breath. Now, I asked you, what is the soletus relation of the great arteries?
The pulmonary artery is left and anterior, sir.
Yes.
Aorta right and posterior.
Anterior, there are three. In space, we need three positions.
Yes, sir.
Aorta is
Right and posterior.
right.
Posterior.
And
Remember,
caudal.
rest in peace. Aorta, rest in peace. Right? Inferior,
And
posterior. So obviously the pulmonary arteries are superior, anterior to the left. Okay, next. What is meant by soletus? Situs soletus? In
Site-
general,
ab-
what is what
abdominal-
does situs mean?
situs.
See, the whole body of
Yes, sir.
all animals, okay, is actually symmetrical.
Yes, sir.
Okay, the right and left have got the same, except for some structures which are not paired. Okay, those structure positions determine the soletus, that is the position in the body. Okay, unpaired organs like that. And any structure is described in space by x, y and z axis. Okay. So like that, aorta is described as actually to the right, to inferior and posterior. Pulmonary artery is superior, anterior and left. So you explain in space like that.
Another point to add, that is the visceroatrial situs. So your trilobe bronchus will be on the right, bilobe on the left, liver will be on the right, spleen on the left. Your
Sorry, I just out of curiosity, can I determine the situs looking at you, but not her? Can I determine the situs looking at you, examining you, and not her? It's a clue.
Abdominal situs can be confirmed by...
Oh, you look at my tummy, your tummy and her tummy, you can make out the thing. I'm giving a very pointed clue that there is something in you which is not there in her, literally. What do you have which she doesn't have externally, which can be seen? Please don't tell me. The symmetrical structure. Can you tell me an asymmetrical structure which is there in you and not in her? Right? External examination. In general surgery, no male or female should be examined without removing the undergarment. So I am literally stripping you alive. So now tell me, what would you look? Are testes symmetrical? Yes or no?
No, sir, they're not at the same position.
Not in the same position.
So,
Why?
what is the natural history of a VSD? The echo. There is something happening in this VSD. Can you tell us the natural history of VSD?
Yes, sir.
And
So, depending on the age of presentation, a percentage of the VSDs go towards spontaneous closure. So, at 1 month of age, 80% of the VSDs proceed to go on to spontaneously close. At 3 months, 60%, and further on, at 1 year of age, 25% of the VSDs tend to close. Also, the closure also depends on the location of the VSDs, number of VSDs. This is for spontaneous closure, and mechanisms of closure could be because of adherence of the septal leaflet of tricuspid, or adherence of or prolapsing of a right aortic valve cusp, or maybe because of infective endocarditis, or possibly even a Gazul phenomena, or a developed acquired pulmonary infundibular hypertrophy. Other,
This patient you want to operate or not?
I would want to operate this patient. One,
Restrictive VSD, why you want to operate?
there is presence of aortic regurgitation. Sir.
Do you expect this VSD actually to be big or small?
Small, sir.
He's saying 6 mm. This VSD is actually a big VSD which has got closed.
Yes, sir. Yes, it was initially big, sir, because the symptom is also it was big, and then it has been restricted.
can we?
You are talking about AR, that is what is closing the VSD.
Yes,
no?
sir.
Prolapse.
Yes, sir.
So why did you not say that?
Pardon me, sir.
No, the VSD closes by prolapse of the.
Yes, sir.
So that is what you answer Prasanna sir's question, no?
Yes, sir.
Though the VSD looks small on the echo side, it's actually a large VSD.
Yes, sir.
So what kind of VSD is this?
This is a perimembranous VSD, sir.
How do you define a perimembranous VSD? How will you label a VSD as perimembranous?
When it has relation to the membranous septum, sir, and also.
How will you know where is the?
Yes, sir. No, sir. We will not.
If it's a defect,
Yes, sir.
you won't be able to see. So
Yes,
how will you know that this VSD is perimembranous VSD? That is number one. Second thing is, how do you search for a perimembranous VSD? Where do you search for it?
Okay, sir. There will be mitral, tricuspid, and aortic continuity in a perimembranous VSD. That is the
You will not
characteristic.
be able to see the mitral annulus at all.
Yes, sir.
But through the VSD, one of the margins of the VSD
Could be
will
the-
have aortic and tricuspid.
Yes, sir. Yes, sir.
Okay, so that defines what is meant by a perimembranous VSD. That is
Yes.
one definition. Where do you search for a perimembranous VSD on table?
Trans RA, I would put my RA stays and 10 at 2 o'clock and one stay posteriorly at 6
Fine.
o'clock. Then the septal leaflet, I would elevate it, and I would expect it to be near the anteroseptal commissure at the
Exactly.
aortic and tricuspid.
Exactly. So you search for perimembranous VSD at the anteroseptal commissure, beneath the anteroseptal commissure, below the septal leaflet. Okay.
Oh, I thought I was drawing the picture.
What is this?
You keep talking, you keep talking.
Okay. How do you identify the septal leaflet?
Sir, the septal muscle of Lancisi will be coming from the
What
septal
is
leaflet.
meant by muscle of Lancisi? How do you know that a particular muscle is a muscle of Lancisi? How will you know that?
The septal, it's arising from the septum, sir. It is
That
a
there will be
characteristic
at various levels of the septum, there will be multiple
the-
attachments to the septal leaflet.
It will
So
be
how will you know?
the first one, sir. It will be the,
No, it is the last one.
I mean,
It is the last one. So the septum starts from the crux area, okay, and it ascends up towards the
Yes,
outflow
sir.
tract. So the first one is actually towards the crux.
Yes,
Or if you are telling the reverse order, then the
Yes,
first
sir.
one is the muscle of
once I
Lancisi.
open it and I see the first one, which I see near the crest.
Ah,
board,
but
that
that's
would
not
be
the
septal.
first one. Actually,
Yes,
it is
sir.
the last one. Why do we say it's the last one? Because we assume that the outflow tract is the exit point, isn't it?
Okay, yes.
So that the last papillary muscle giving attachment to the septal leaflet is called as the muscle of Lancisi. What is the surgical importance of muscle of Lancisi?
Sir, one, this would tell me about the VSD if it has inlet extension. Other thing, while closure of the VSD,
Why
I
do you
should.
need to know whether there is inlet
Yes, sir.
extension? Surgical importance.
Yes, sir. I would want to avoid taking the VSD and restricting the tricuspid valve during my closure VSD.
So this is point, muscle of Lancisi is considered as the second point to delineate the conduction bundle. Okay? The first point is the apex of the triangle of Cox.
Yes.
That is point number 1. The base of the muscle of Lancisi is point number 2. The imaginary line joining these 2 points is the course of the bundle. Okay?
Yes.
So that is the surgical importance of the muscle of Lancisi.
Thank you.
And the second surgical importance of muscle of Lancisi is in cases of tetralogy, above the level of muscle of Lancisi, all bundles can be excised if provided they don't give attachment to the caudal apparatus. So the muscle of Lancisi gives the limit above which the resection in tetralogy of fellow is done. Okay? So
Yes,
these
I
are
want to
surgical.
have a little poll. How many of you students, all of those who agree that this is correct, raise your hands. If you are not raised your hand, you are saying it's incorrect. So now, how many of you think it is incorrect? Raise your hands. Are nobody raised their hands for this and nobody raised. No. How many of you think that this is correct? Raise your hand. As a consequence of it, all of you who think this is incorrect, raise your hand. Nobody raised their hands for anything here. No, I'm very honestly telling. This is the statistical chance of you getting this, one of the 5 figures I tell is 100%. What is your objection to this figure? What is this? BIF? Ventriculo-infundibular fold. What would Professor Jayan just tell you? Where will be the...
Can you define what is ventricular-infundibular fold? Do you know the definition?
It cannot be here.
So ventricular-infundibular fold is a band of muscle
Yes, sir.
which lies between the semilunar valve and the AV valve.
Yes, sir.
In our case, it is the right ventricle. Isn't it? So between
Right.
tricuspid valve and the pulmonary valve, the muscle fold which lies in between is actually the ventricular-infundibular.
It's called in essence the inner curvature of the heart. So that cannot be there. Number 2, where is the papillary muscle of Lancisi? You never drew that. Where will it be? It will be here. It will be here. And now another thing that I want to tell you.
Shrikant.
How many of you think that you can see the aortic valve like this? The baby's bottom ventricle. If I have the baby's bottom fully seen this side, what does it mean? If I could see the entire aortic annulus and the valve on this side of the septum, what does it mean?
Overriding.
It is 100% overridden, so you cannot see it like this. What you see in a normal VSD is the baby's bottom comes through the, you are seeing the baby's bottom through the VSD. Only when you actually, that is why I say, new cardioplegia, you would actually see the baby's bottom. what you are seeing here is the anterior annulus, anterior portion of the annulus. This is the baby's bottom, the posterior annulus is down there. Draw the coronary sinus tendon of Todarum. And how do you demonstrate the tendon of Todarum? How to demonstrate on table the tendon of Todarum? Can you see the tendon of Todarum?
Yes, sir.
You really see it every time? Really see when I look, you see the tendon of Todarum? You've seen it?
If it's very
Sir,
prominent,
sir,
yes,
shown
it can be seen. But most commonly it will not be seen.
Yes, sir.
So if you just hold the fold of tissue, the valve, near the IVC and pull it, that becomes prominent.
How do you demonstrate it? You take the lateral lip of the coronary sinus. See, the eustachian valve will be like this, the coronary sinus comes like this, the mesial valve. If you pull, when you pull it, there is only the tendon is attached with the AV node that side and the
Coronary sinus.
spinal septum that is which is between the coronary sinus and the eustachian valve. When you pull it, a ridge forms and that ridge is actually the tendon of the valve. You don't, it doesn't actually be seen on the cardiac surface. You have to educate it.
So regarding the structures on the right ventricular surface, regarding structures in the right ventricular surface, all the important points related to surgery are deduced. They are not identified. We don't say that this is the muzzle of Lancisi. No, we don't say that. We actually go by landmarks and deduce the structures. So the first structure that you will identify is actually the tricuspid valve annulus, and the most common exposure will provide the septal surface on the right side, and the leaflet attached to this with its attachment on the septal surface is actually the septal leaflet. So far okay? So this is the first. Then you identify the triangle of Koch. The triangle of Koch's apex is marked point A. This is kept in mind. So this is where the conduction system is supposed to start for related to the surgical relevance. The last of the septal attachment of the septal leaflet, okay, the papillary muscle giving rise to the last attachment is called as the muzzle of Lancisi. So this is a deduction. This is point B, the base of the muzzle of Lancisi. The line joining these two is where the conduction system is. This is about the conduction system and the septal leaflet. Next, at its last part of the septal leaflet, there is the anterior mitral leaflet. This is the anteroseptal commissure. This is supposed to form part of the VSD margin in perimembranous VSD, because here is the last place where the aortic annulus will come in contact with the tricuspid valve annulus. So this is the anteroseptal commissure. Most commonly this is the place, and this is also a marker for identifying the membranous septum. So based on these landmarks we identify structures. Then comes structures which are important for tetralogy of Fallot, where if suppose we visualize the RV cavity, any bundle which is the most prominent among the bundles, let us assume there is septum like this. This is the inlet portion. This is the outlet portion. If there is any bundle which has got the most prominent, okay, that bundle is called as the trabeculoseptomarginalis. So it is a deduced. Once the TSM is identified, you can realize that actually it continues towards the inlet and continues also towards the outlet. These are called as the limbs of the TSM. So this is called as the posterior limb going towards the tricuspid valve, anterior limb going towards the semilunar valve. The semilunar valve and the atrioventricular valve on the right ventricular surface is separated. They are not in continuity, and that separation is actually connected by a muscle band. This is called as the ventriculoinfundibular fold. And coming to the lower part of the TSM, there is a portion of the TSM near the apex which connects to the free wall of the RV. That is called as the moderator band when it is the most prominent. There can be some bands which connect the septal surface to the free wall, in the outlet portions, they are called as septoparietal trabeculations. So, and then above the muzzle of Lancisi is what we call as the infundibular portion of the RV. Outside, from outside, the same portion is called as the conus. Why do we call conus? Because a large part of the cavity has to get connected to a small cylinder. The only way a cylinder connects to such a large cavity is by a cone. That's why we call it as a conus. So beyond this, if you need anything related to anatomy in the RV, you ask, we will tell you. The attachment of the septal leaflet. So suppose this is the right ventricular septal surface. There is attachment of the septal leaflet with various chordal. They mark the portion where actually the inlet can be defined. The apical portion is where the entire trabeculations are there, and the muzzle of Lancisi marks the border for the outlet. Okay. Yeah, now you continue.
Okay, sir. Yes, sir. There are two approaches, sir, that we could do. One is through a trans-aortic approach and tackle the aortic valve. Yes, sir. This being a perimembranous VSD with AR, a trans-RA approach to close the ESD, and in case there is AR which is significant, it can be tackled through a trans-aortic approach. That's what.
Please avoid trans-aortic.
Yes, sir.
You are correct that a trans-aortic approach
Yes, sir.
can be done because I do a trans-aortic
Yes.
approach. I do everything through the aorta. But
Yes, sir.
for you, always tell the easiest
Yes, sir.
first, the conventional thing.
Now
That is,
we will keep that question. In which situations do we close VSD by trans-aortic? Okay, there are indications for that. But I think it's
Yes,
preferable you go slow. Means learning should be in a stepwise manner.
Yes, sir.
It's a gradual escalation and refinement of your skills. Okay.
Yes, sir.
So it is actually through the RA, trans-RA
Trans-RA,
approach
yes,
would
sir.
be the most preferable.
Yes, sir.
Which side of the ventricular septal surface do VSDs appear more clear?
On the right ventricular, sir.
No, it is not. On the left side, all VSDs have got beautiful clear margins. Okay, it's very difficult margins to appreciate on the right side. Despite that difficulty, all VSDs are closed from the right side. There are select indications where you close from the left side. We will not go there. Now you just go trans-RA and tell us how you are going to close the straightforward, simple, large perimembranous VSD.
Okay, sir. So, we go for a medium sternotomy after? No, directly.
You have exposed.
Aorta bicanal cannulation is done. I'm open there.
You have opened the RA.
Okay, sir.
Now, from now.
Yes, sir. So I'll put traction stays on the right an RA to at 10 o'clock and 12 o'clock, 10 o'clock and 2 o'clock, and one at 6 o'clock position. Then I will visualize my VSD.
I don't see the VSD.
I will retract the septal leaflet of tricuspid and anteroseptal commissure, and
I don't see the VSD.
then even
Detach the leaflet and
Before detaching, destructive detaching, what are the
I
other
can-
links for a VSD?
I can fill the left ventricle through the RSPV. I can fill and look for.
I still can't see it properly. What are the other clues before you do that? By inspection, which give you a hint.
That there could be a VSD in this place.
The jet of the VSD, if it can cause opposite, you would.
Exactly the
Yes, sir.
opposite side you will find the jet lesion. Okay?
So it will be fibrosis and reaction.
Okay.
So
this patient has an AR, so we can give
You
plates.
can actually give
Give
cardiac
plate
lesion
Janssen.
and you will find where the blood is leaking.
yes, sir. So I would plan for a partially continuous and partially interrupted closure, sir. So for my continuous, I would first take my pleated sutures at the
What suture, what needed, what
5013 mm TF suture material, proline. I would be taking. Pleated I would take, sir. For this is for the at the base of the tricuspid septal leaflet of tricuspid. I would take these, sir. But my continuous suturing I would plan from the ventricular infundibular fold. at the, basically the transition, the transition point between the septum and
No, why don't you just say where it is comfortably visualized,
Yes,
there
sir.
is no difficulty in suturing, you go for continuous.
Yes, sir.
Wherever there is difficulty, you just take interrupted.
I tell you a simpler thing. Just
Yes, sir.
say I will do interrupted throughout. No.
Yeah,
I want to invite more questions.
no, even the consultant that you must be working with would do, wherever it is simple to do, you would take a continuous.
Safe margin compared to where is it safe?
my posterior inferior, I would expect the bundle, sir. So,
Okay, let us go back to basics. You define what is anterior, posterior, superior, inferior in a VST.
okay, sir. So my anteriorly ventricular infundibular fold, superiorly I would have the aortic.
Again, it's wrong. It's not like that. I will tell you. Anterior, posterior, superior, inferior does not change in the heart.
Okay.
And the most anterior structure when you are operating is the sternal retractor.
Yes, sir.
Any margin which is close to the sternal retractor is your anterior margin.
Yes, sir.
Any margin which is closer to your spine is the posterior margin. Any margin which is towards the foot is inferior margin. Anything towards your head is the superior margin. This is how the margins are. Okay. So you don't define in your this ventricular like that.
Yes, sir.
On the table, its orientation is determined by the same anatomical entities as anterior, superior, posterior, inferior. Okay.
Yes, sir.
Please tell me where will you take the continuous? There has to be that. See, always remember we see bumps and holes. That's all that we see. So you are so now to find out where you are this thing, you should define a bump and you have to define a hole or something like that. That's all you see. No? You see a bump or you see a hole. Now you are going to tell me from this bump to that hole or this bump to this bump or this thing, I can be safe. Your boss, I confirm from your boss that that is the method you want to do. Now where are you going to put the continuous? From which side to which one?
So at the
No, you still have time. I think you change over to interrupted. Life is easier.
Because you start anywhere and tell me how will you go around. Interrupted sutures, that's all. 2
Okay.
minutes, last question.
Sir, at the junction of the septal leaflet of tricuspid, at the base of it, I can take my interrupted suture, sir, and and I'll 3 to 4, depending on how the size of the VSD, I would take it and keep it under traction, gentle traction.
Continuous suturing. Where will you say that you are safe? Bindas layer ka sakta hai.
And
The
anterior and
No.
uh,
Don't use these things.
and
No, I'm telling you don't use these things.
anteriorly, I would be wary of the aortic valve, so there my suture has to be superior.
Superiorly aortic valve.
Yes, sir.
So which is the safe zone? From what landmark to what landmark are you safe? Whether you do interrupted, continuous, anything, you are safe there.
the muscular health. Where?
Which portion? From the papillary muscle of Nancy up to the aortic valve, you are
Yes, sir.
safe. That you do any sort of suturing.
Yes, sir.
But you have to be careful from aortic annulus all the way from the base of the septal leaflet up to the papillary muscle of Nancy, isn't it?
Yes, sir.
That is the danger zone.
Yes,
What
sir.
are you protecting?
The bundle, sir.
No, bundle.
And the aortic valve, please.
Right into the danger zone.
Yes, sir.
Are you happy with your You want to draw the picture there of the television? Tea break, huh? Lunch break for the teachers and tea break for the students. No, we are having lunch. Oh, it's lunch time. 1 o'clock.
So much, sir, and residents. Now it's a lunch break, and two announcement for that. That first is there is an IACTS Cone 2027 counter also for early bird registration. And secondly, after lunch, there is a selfie zone on 4th floor. So you can have your selfies as well as you can collect your check for IACTS travel grant.
I would ask all of you guys to come up with some questions which you want to be answered. In the subsequent sessions, we can answer those questions if you want to know anything.
Okay.